Hello, everybody. Welcome to our webinar. I'm Professor Paul Lee, orthopedic surgeon. Thank you very much for the college to give us the opportunity to present our education series to you guys with the Royal College of Surgeons Advisory Network. Today, I would like to introduce our speaker, Eamon Kunda, who is a very good colleague of ours. He's an orthopedic surgeon that is working at Salford Royal Hospital, which is a major trauma center. Eamon has a lot of expertise on lower limb reconstruction, and he has done numerous fellowships. His main interest is in lower limb arthroplasty and reconstruction. Today, we have a great pleasure for him to explain to us about how to look at hips. And as you know, although hip pathology is extremely common, and we will all deal with it in some part in our career. It is very important for us to familiarize ourselves to how to deal with painful hips. And Eamon is going to talk to us about how to assess them, examine them, and also talk to us about different differential diagnosis and how to manage hip fractures. Over to you, Eamon.
Thank you, Paul. We're going to talk today about hip pain, and the goal is, as Paul has mentioned, we want to learn about how to assess pain originating from the hip, how to carry out focused examination for the hip joint, and also we'll discuss some common differential diagnoses, and also we'll explore the management of hip fractures, because this is a common topic that every doctor will come across during their career, regardless of their specialty. So when it comes to pain, I think pain in every part of the body, you need to remember Socrates. So site of pain, it's very important, and it tells you a lot. So any pathology or any pain originating from the hip, it is most likely to be felt in the groin, and usually if it's radiating, it would radiate down the anterior aspect of the thigh down to the knee. You can also have trochanteric pain, and pain around the greater trochanter usually is related to trochanteric bursitis or abductor tendinopathy or tendinitis, but it can also occasionally signify a hip joint pain in origin. Pain in the gluteal region is less likely to be originating from the hip, and it's more likely to be originating from lower back. So when it comes to site, you need to keep in mind where the pain is actually, so that you'd be able to explore that further with your history. And then it comes to the onset. So if the pain is sudden, then that usually is related to trauma, acute fractures. It could be acute as in infections, or subacute as in avascular necrosis, or it could be more chronic process like osteoarthritis or inflammatory diseases. And then it comes to the character of the pain, and we're talking about, is it a sharp acute pain, stabbing pain, or is it more kind of a dull ache or arthritic pain? And the radiation we've already kind of mentioned slightly with the site of the pain. But to give you more examples, so if you have, let's say, gluteal pain that's radiating down the posterior aspect of the leg and it's going down to the foot, then this is most likely back in origin due to nerve compression. So there's a radiculopathy or sciatica, what's called. And then you talk about, you want to explore the associated features with the pain. So does the patient have any night pain? Does he have any sweats, weight loss, and these kind of red flags? Do they have temperature? Are they tachycardic? Are they in shock? Then you're thinking more infection. Do they have any involvement of other joints, which indicates maybe an inflammatory process, rheumatoid arthritis? Do they have any eye problems, any urethral problems? And you start thinking about Reiter's syndrome. So all these things you need to look into. And then the time course of the disease. So how long has it been going on for? Does it have peaks and troughs? What makes it better? What makes it worse? So typically arthritic pain is better at rest, worse on exercise. And then you want to explore the severity. And the severity is not only for the peaks, but also for the background level of pain, because pain you can still have a background level of pain, but it peaks at certain points. And then we move on to carrying out a clinical examination of the hip. And when you're examining the hip, you examine the patient in 3 positions. The first is standing, second is sitting, and last is lying down supine. So in standing, you would be carrying out your orthopedic examination as per look, feel, move. And with that respect, you'd be looking for any scars, sinuses, deformities, swellings. But then you'd come to assess your leg length. And the easiest way of doing that is make the patient stand, have your hands on their iliac crests, and see if your hands are at the same level. And if they're not, you might need to put a block underneath the shorter leg. And the difference is, and the leg length, the discrepancy is the thickness of that block. You then move on to carrying out what we call a Trendelenburg test, and that is a test of the integrity of the abductor muscles. So the picture on your left hand shows that the patient is standing on both legs and the pelvis is level. In the middle is standing on his right leg, and you can see that the pelvis tilts up. It means that the abductors on his right hip are functional and are supporting his body weight and keeping his center of gravity over his right foot. Whereas the picture on your right-hand side, you can see that the pelvis has dipped down, meaning that the abductors on the left leg have failed to support his pelvic and body weight. And as a result, he's leaned over his left side, so we call it a lurch, in order to maintain his center of gravity over his foot so that he doesn't fall down. And that's a positive Trendelenburg test. The last thing you want to do when a patient is standing is examine their gait. And when you're examining a gait with respect to hip, you'd be actually watching what's happening to the head of that patient. So if the patient is walking and the head is swinging side to side, then they probably have a Trendelenburg gait. And that is what we discussed in the previous slide, because they're going to lean side to side to maintain the center of gravity. If the head is going up and down, then they probably have a leg length discrepancy. You'd then be moving on to sitting down, and the test that you're going to do there is a psoas test. And we all know from the anatomy picture that I've got there that the function of the psoas is actually flexion of the hips. So if the patient is sat down, you ask them to raise the knee up and you'd be pressing down on it, and you ask, do they feel pain in their groin or anteriorly in the hip? And that is a positive psoas test. And then you get the patient to lie supine, and again you repeat your inspection. You square the pelvis, so you have both hips at the same level. You bring the feet together so that they're aligned symmetrically and lying symmetrically. And then you start palpating. So what would you palpate in a hip examination? Well, you palpate the trochanteric regions. So if there is any trochanteric bursitis or tendinopathy, that will elicit tenderness. You'd palpate the femoral head as well. And you'd palpate, when you later on turn the patient supine, you can palpate the ischial tuberosities. And then you'd be carrying on your further examination of the patient is supine. So you'd carry out your leg length measurements, and that would be the true difference and the apparent difference in the leg lengths. And you need a fixed bony landmark for the true and a central landmark like the umbilicus or the xiphisternum for the apparent leg length. And you can see the difference in those. So if there's any deformity in the spine, then the apparent leg length would be probably different. But maybe if you measure the true, you'd find that it is actually not different. And that's what the difference between the apparent and the true leg lengths are. You then move on to performing a Thomas test. And now when I perform a Thomas test, I'd like to start with the picture in the middle. So you can see that patient has both knees held up towards the chest. And doing so, that will obliterate the lumbar lordosis and will put your pelvis square on the table. And you keep one knee up and you let the other knee go down. And if the leg goes down and touches the couch and the knee's flat on the couch, it means that there's no fixed flexion deformity in that leg that you've lowered. Whereas you can see that in the picture where the boy is facing us, the younger boy is facing us, you can see that his hip remains flexed for about 15 degrees, which indicates that there's probably a fixed flexion deformity of 15 degrees in that patient's hip. In the pictures at the bottom end of the slide, you can see when the lady was examined, she had no fixed flexion deformity in either hips, but the older gentleman on the right-hand side has about 40 degrees of fixed flexion deformity in his left hip. And then you'd move on to carry on the rest of the examination of a hip joint. So you'd be doing abduction, adduction, rotations and extension and flexion, and also you can do a hip extension movements with the patient lying prone. And at that point, you'd palpate the ischial tuberosities as well. And this is a reference for the normal range of movement in a hip joint. So typically, these are the values that you're going to record. When it comes to making up your mind, so you've taken your history, you've examined the patient. When it comes to making up your mind to what is actually going on wrong with this patient, there's a diagnostic calendar in hip pathology that helps you and guides you towards the diagnosis eventually. So it's common in the first 5 years of life, we talk about development dysplasia in the hip, so congenital hip dislocation and the likes. Pardon me. In the second 5 years of life, you'd be talking about transient synovitis, Perthes disease, and 10 to 15, you'd start about slipped upper femoral epiphysis. But then we get into adulthood, and then the first pathologies that we face there are probably ankylosing spondylitis and inflammatory diseases. And then we'd come on to secondary osteoarthritis, and these secondary osteoarthritis possibly are related to pediatric conditions such as Perthes or DDH during childhood or SUFI. And then the last is primary osteoarthritis and also hip fractures. So the common differential diagnosis that I've chosen for you to discuss and have a brief discussion about was osteoarthritis, avascular necrosis of the hip, infection, and hip fracture. In osteoarthritis, typically the patients that we've just learned are older patients. So they are probably in their 60s or 70s. You'll have pain typically in the groin, and that radiates down the anterior aspect of the thigh to the knee. The onset is gradual, so it starts as mild pain and it builds up over months or maybe years. So it's not an acute process, and typically gets worse with exercise. When you examine those patients, you'll have that the range of movement is reduced. So you might have a fixed flexion deformity in the hip, and with a positive Thomas test, you might have reduced internal rotations, reduced flexion. These are the movements that you start losing first when you examine those patients. Avascular necrosis, patients with avascular necrosis are slightly different. So those patients are a little bit younger, so 35 to 50, usually male. It is usually bilateral, but they don't necessarily present simultaneously. So they present with one hip and later on the other hip. And you'd want to be looking for risk factors for avascular necrosis. So there's a long list of risk factors why patients develop avascular necrosis. Common ones are like steroid and alcohol, but there's many more risks. The presentation is usually insidious. So you'll have an acute or subacute presentation of hip pain, and that is related to the avascular event. And I'd like to think about it as something similar to a heart attack, but it's actually in the hip joint, because that is exactly what's happening. When you have a heart attack, you lose a blood supply to part of the heart, and it's acutely painful. And it's very similar in the hip joint. You cut off blood supply to part of the hip, and it's acutely painful, and you may get, and those patients can seldom present acutely to hospitals, but then you investigate and you wouldn't find any infection. And as time goes on, they gradually develop symptoms similar to osteoarthritis, and you find that they have a painful range of movement, etc. The other differential diagnosis that we'd like to draw attention to is septic arthritis, and these usually have an acute onset because of the nature of it. So the patient typically present with systemic symptoms, tachycardia, pyrexia. They may have hypotension, they could be in shock, and it could be a life-threatening condition. So it's serious. So it's important to diagnose those early and be able to treat them. They typically are unable to weight bear on their hip, and they will have localized signs when you examine them. So it could be redness, swelling, tenderness and palpation. The limb will usually be held, so the hip will usually be held in a flexion, abduction, external rotation. And why is that position? Because it is the position where the capsule is least stretched naturally. And that would allow the capsule to accommodate the synovial effusion or the pus and the infective process within the joint. And they will have severe pain on hip movement. So if you try to move the joint, any passive movement, it will produce a lot of pain. And you need to think about the criteria that would make you suspect infection. And these are in orders of importance, are fever, any raised CRP, a raised ESR, a patient inability to weight bear, and also raised white cell count. The other topic, which is quite important, and I mentioned that probably every doctor will come across in their career, is hip fractures. In Great Britain, we treat around 70,000 patients with hip fractures annually. They have a mortality rate of 10% at 1 month and 30% at 1 year. And the total cost of the treatment is around 2 billion. So it's a hugely important topic, and it's very relevant, and you will come across it. The approach to those is usually multidisciplinary. So the patient is greeted by ED, seen by orthopedic surgeons, orthogeriatricians, anaesthetists, rehab physicians, and practitioners. So it's a multidisciplinary approach, and there are nice guidance on the management of those injuries as well. So when you come to assess those patients, you want to assess the mechanism. You want to ask about the mechanism of the injury. Is it a low energy, falling from standing height, indicates osteoporosis, and you need to take that into consideration when you're going to eventually treat those patients? Or is it high energy when you think about are there more injuries than this? Is there anything else that's happened to this patient? You want to know if they've had any pain prior to the fall, because that can indicate that it's a pathological fracture. You also want to know about the circumstances of the fall. Did they actually have a chest pain and fall down? Did they have a stroke? Was there a syncopic attack? Did they have a chest infection? Have they fainted? You want to be, because you want to know about all these so that you can treat them simultaneously as the hip fracture is also being treated or subsequently. You also want to know how long was the patient on the floor for, because they unfortunately, some elderly patients would fall and they will not get help till the very next day until their carer or relative comes in for a visit. So they could spend a very long time on the floor. And what would that precipitate? Rhabdomyolysis. So rhabdomyolysis, an acute kidney injury, can be a serious complication of being laid down on the floor for a long time. You also want to know about their mobility issues. Did they use any walking aids? That will, affect your rehab targets and discharge planning. You also want to get some collateral history if the fall has been witnessed by someone else. Those patients usually present with multiple medical problems, and it's important to learn about all of these because you'd have to carry out a holistic assessment of those patients and look after the patient as a whole, not only the fracture, as usually orthopedic surgeons say. You also want to know about their medications. Some may need to stop, some may need to alter. So are they on steroids? Are they on anticoagulants, antiplatelets? All these, you will have policies and guidelines of what to do with them in order to prepare them for their surgery. And again, you want to know about the social history. Do they live alone in a flat? Is there someone else to help them at home? And again, that will come into your rehab targets and discharge planning. You'd also carry out a systematic review. When you come to examine them, you do exactly the same thing. You will examine them top to bottom, but let's focus on the musculoskeletal findings here and see what we're going to find. You will find often that the leg is shortened a little bit, externally rotated. The patient is unable to straight leg raise. There is pain on attempted movement. There is tenderness on palpation of bony landmarks around the hip. You also want to assess the skin, the integrity of it, because that's where you're going to do your operation. You want to assess the distal neurovascular status of the limb, which often is normal and unaffected by this injury. And then you'd carry out your radiographic examination. And let's remind ourselves of the hip anatomy. So the hip is a ball and a socket joint made of an acetabulum, a femoral head, which is connected via a neck to the rest of the femoral shaft. And it's important also to notice, as you can see on this slide, that there's a capsule that surrounds the hip, and that capsule is responsible for a lot of the nourishment and the blood supply to the femoral head. So any injury that takes place within what is labeled on this slide, the intracapsular, or within the neck, is actually an intracapsular fracture. So any fracture that happens within this region is called an intracapsular fracture because it's within the capsule boundary. Any injury that happens outside of this, so in the intertrochanteric region or in the subtrochanteric region, this is an extracapsular fracture. And these are important because it has bearings and affects the way that we're going to treat those injuries. So for the intracapsular fractures, there is a classification from Gardin. Gardin was a surgeon in Preston. He's devised this classification system for intracapsular fractures. So the fracture is not displaced. It could be either 1 or 2, or is it displaced and it's a 3 or 4. And that depends on the degree of displacements of the fracture, really. And these are important because the survivalship of the femoral head is going to depend on its blood supply. And if you can see that the blood supply to the head is very peculiar, it comes from a branch of the femoral artery, which is the deep femoral artery, that gives 2 circumflex branches, which will form an anastomosis around the base of the neck. And then these anastomoses will send some ascending branches underneath the capsule that's covering this neck, and these branches will eventually supply the head with blood. There's another small blood supply from the artery of the ligamentum teres, which connects the acetabulum to the femoral head, but this is less reliable in adult patients and more relevant in children. When I say children, very young children. So any fracture that's going to go through the neck is actually going to go through all these vessels, and then you're left with a head that has very little or no blood supply. And that's why it is important to know where the fracture is. Is it intracapsular or extracapsular? And if it's an intracapsular, is it displaced or not? So this X-ray would show you that there's a fracture through the neck. It is displaced. So most likely all these vessels that we've just seen in the previous slide have been severed. So consequently, that head is most likely going to die as a result of this injury. Whereas this injury is extracapsular. It's in the intertrochanteric region, which means that the blood supply to the head is spared, and hence there's no or very little threat to it. This is a fracture that is actually in the subtrochanteric region of the proximal femur. So the blood supply to the head is well preserved in this one. So the quick and easy way to remember what you need to do is, if you have an intracapsular fracture that is not displaced, then you can pin this. And you can use any device to pin this. You can use what I showed you here, which is a dynamic hip screw, or you can put individual screws, which we called cannulated hip screws. So if the fracture is intracapsular, it's not displaced, it means that the vessel are probably intact. You can pin it in situ. Whereas if the fracture is displaced, then you've got no choice apart from replacing it. So if it's a Gardin 3 and 4, you bend the head and you replace it with a prosthesis. And this is a hemiarthroplasty of the hip. If the fracture is extracapsular, we've learned that there is no threat to the blood supply of the head, and hence you can fix those fracture. So the picture on your left hand is the dynamic hip screw, and the one on your right hand is a cephalomedullary device, and there are a variety of these on the market. So in summary, if you're dealing with a hip fracture, then you need to know whether this is intracapsular or extracapsular. We've learned that the extracapsular ones spare the blood supply, and hence we can fix those, whereas an intracapsular one depends as to whether it's a displaced or undisplaced. If it's not displaced, then the blood vessels are probably intact and we can fix them. If it's a displaced one, then we should be thinking about replacing that broken femoral head. And to sum up, when you come to approach a patient with a hip problem, you need to remember Socrates in your pain assessment and in your pain history. When you're examining a hip joint, examine the patient in 3 positions: standing, sitting, and supine, so that you have a general idea about the patient. You need to remember your diagnostic calendar. This is very helpful. These slides will be available still later on for you to view. So the diagnostic calendar gives you a clue about what to look for and what to assess for with your investigations. You need to remember your clinically relevant criteria for decision making when it comes to suspecting infection. And hip fractures always treated as an MDT, so you always have multiple people involved in that from different specialities because it's a complex issue that requires a multidisciplinary approach. Thank you.
Thank you very much, Ingrid, for this really good lecture on around the hips. And yeah, we got some question coming through over the on the Q&A sessions. One thing I forgot to say at the beginning is that yes, we can use the Q&A questions tag to ask us any questions. And if from our attendees, if there's any question, please ask away on the Q&A questions now. I have been answering some of the questions on the Q&A side, and basically there's a question there. A couple of people are interested. Is when we on examination on the patient, how can we tell that when the pain is actually coming from a fracture instead of from a hip arthritis?
Yeah, so I think you're going to learn about that from the history. So when you come to assess the patient, then you'd need to know, has there been a fall? Was there a history of trauma? So patients that would present with a fracture, they will typically have had a fall or an injury to the hip, and then they're usually unable to weight bear following that. So you wouldn't be able to perform the whole examination that I've mentioned and described in this presentation, but you'd be able to probably ask them to straight leg raise. Can they do that? And if they can, then you can actually support the body weight, the leg weight, and then see if you can move it any further. You can do some rotations and take it from there. But usually if they have a fracture, then they wouldn't be able to move that limb and wouldn't be able to raise that leg. If they can, then it's usually unlikely to have a fracture, or could be a small fracture that's subtle, undisplaced, and stable for you to be able to examine them, examine their hips.
Great, absolutely. I completely agree with that. And I think the straight leg raise tool is extremely useful. There's some study that say that when you can do straight leg raise, the hip force is actually almost double to the body than you're actually walking. But so it's an extremely useful way to distinguish them. So there's another question coming through now, and they ask about the treatment pathway for septic arthritis and what time frame.
So septic arthritis is an orthopedic emergency. We'd like to think about it that way, because once the septic process starts in the joint, then you have the enzymes digesting your articular cartilage. So you need to be able to treat those as soon as possible, and even if that means in the middle of the night. So where I work in Salford, this is for us is an orthopedic emergency, and if we diagnose a septic arthritis, we don't sleep on it. We take the patient to theatre, do an open washout and drainage, clean all the infected material on the hip and wash it out thoroughly, and then commence IV antibiotics. And then we keep re-evaluating the patients because they may need more than one visit to theatre. So it's a dynamic process, but you need to get on with it as soon as you can. There is some evidence that delaying treatment more than 6 hours is actually detrimental to the hip or to any joint. And you may actually start losing all of your cartilage by then. So you need to get on with it as soon as you can. As soon as you diagnose it, you have to get on with it.
Absolutely. Thank you very much for that. That's a orthopedic emergency. I completely agree with you. And I think after fracture, septic arthritis is, the major thing that we, as orthopedic surgeon, we need to deal with very quickly. I got a female question here, which is quite interesting. It's about more like an instability type thing. So it's kind of like a higher level type of question. It's like, how do we examine pelvic instability in patient associated with pelvic fracture? I think that's a really interesting one, and because you work in a major trauma center, you probably deal with all these sort of complex fractures. Share your experience with us.
So pelvic instability is an interesting one. I think, classically it used to be described that the pelvis is assessed once only by an orthopedic registrar or above, by applying pressure to both sides of the pelvis to see if it's stable or not. I think we moved on from that practice, and this is a little bit, dangerous. But if you have a pelvic injury, then this is most likely as a part of a polytrauma. So the patient will typically be in a pelvic binder even prior to arriving to hospital. And if you happen to see as part of the patient rapid assessment a pelvic X-ray with some disruption, then that gives you the answer. If it doesn't, and you get a CT scan as part of your trauma CT, then that will also give you the answer as to whether the pelvis is stable or unstable. And if you ever need to examine a pelvic instability or a fracture instability, we tend to do that in theatre nowadays, and that's more to do with trying to make a decision as to whether the injury requires fixation or not in the pelvis. So we wouldn't typically be examining a pelvis or stressing it in A&E or even in ICU. Now, I know some centers would apply a pelvic binder, but then they'd have certain time limits as to when that pelvic binder should come off, because the binders will apply pressure to the soft tissue, and you might end up with pressure sores and all sorts of problems if you leave it on for a long time. Within our regional guidelines, we are allowed to keep a pelvic binder for up to 12 hours, but in reality, we very rarely need to do that, because most of the time, the patient would have had a theatre visit before then, or if not, then the patient would have actually formed a clot that would be stable enough for you to take the binder off, and they can continue their intensive care on an intensive care unit until they're stable enough for you to take them to theatre. So I mean, the classic way of examining pelvis that's mentioned in the books of putting pressure on both sides of the pelvis, ASIS, and pressing down on the anterior suprailiac spines is not really practiced anymore, apart from in theatre environment when you are deciding to fix a pelvis or not. I don't know, Paul, what you do in your centre, but this is what we tend to do in Salford.
No, I totally agree with you. I think, examine patients down in emergency and everybody go around, have a go and give their pelvis a little push to see is it stable or not. I think that's not a great idea. It is. I agree with you. Have to go to a specialist centre, and I think with in the UK, everything now is based on major trauma centre. If you suspect any issues, they come directly to that centre, and it's rightly they be treated in theatre immediately, and that saves lives. And one final question, which is really interesting, is slightly very different. It's more like to do sport and dancing. It's back to the hips again, moving back from the pelvis. This question is dancer's hip and snapping hip injury. Is it serious? How can it be treated? That's a bit of a headache sometimes, isn't it?
If I'm not mistaken, Paul, we're talking about ITB snapping syndrome here. Is that right?
I think that's what they're referring to, because the dancer's hip, the ITB snapping, and
Yeah. So I'm going to give you my very limited experience on that. I've seen few patients that have this problem, but I think Paul might know a bit more about this than I do. I don't know. So it is a challenging problem. It is a very challenging problem, and it happens usually more, as the question suggests, in younger patients who are active, who are a bit muscly as well, and it is tricky. I think you should try as much as you can not to operate on those patients, because the outcome of surgery is not, let's say, not guaranteed. Or not as reliable as we'd like it to be. So there are very good exercises and physiotherapy protocols that mainly focus on stretching the ITB. That I have my physio colleague in clinic with me who sees those patients teach them, and I've had some good results with those. Others, unfortunately, persisted with a similar problem, but they become less painful. So they kept snapping, but they become less painful because I think the ITB has actually stretched out with the physio, but probably not to a degree enough to stop the snapping, but maybe just about to stop the pain. In the elderly patients, so there's a different pathology, because in the elderly patients with, let's say, recalcitrant trochanteric bursitis, that's a different story. So my approach to those is slightly different. So I usually carry out a diagnostic as well as therapeutic injection of steroid into the trochanteric bursa under ultrasound guidance. And the ultrasound guidance for the older patients would give you a little bit of diagnosis confirmation. So you'd know there's a bursitis, you'd know there's a pathology within the tendon. And I'd go up to 2, maybe 3 of those, and in combination with physiotherapy. And I spaced them out maybe about 3 months. And then it becomes a bit of a challenge, because the next step would be surgery. And I've done a few of those operations whereby you lengthen the ITB. Yes, the pain goes away, but a few of them come back with Trendelenburg symptoms, Trendelenburg gait, unfortunately. The pain relief from that operation is good, but I think you give them a bit of a limp. That's my own personal experience. I don't know about you, Paul.
No, it's one of those heart sink sort of moment when as you quite rightly put it, with the 2 type of groups. For the younger patients, the dancers and the younger, usually happening ladies, because their pelvis tend to be slightly wider, so the Q angle is slightly bigger, and therefore is the ITB stretch a little bit more. And most of the time, it's down to physiotherapy, and it will help. And for the teenagers, for the skeletal immature one, by the time the skeleton become more mature, these problem tends to go away. And nowadays, what we're looking at is, absolutely exactly what you do. Physiotherapy, stretching, gait analysis could potentially help as well, because sometimes they're not holding the pelvis in a certain way. Their pelvis is slightly more flex, and they just basically need some stretching on the iliopsoas that sometimes help. It's kind of like a bit of a balance. But they are very difficult to treat. I completely agree with you. The last thing you want to do is take a knife or do any surgery onto that group of patients. And in terms of the older group, they tend to, a lot of the time, as you say, have a similar symptoms with trochanteric bursitis type thing. And I have a similar experience by doing surgery, lengthening those IT band. Doesn't really help. Well, it does help the pain, but again, they would end up with a slight Trendelenburg gait, and of course, I think the symptoms go away, I guess, because they're not walking as much anymore, and it's not, overusing it as much. But no, it is a very difficult problem to treat. But mainly, I think it's more physiotherapy, and as much as we can, and looking at the global problem. And I think we have a similar approach on that. Even.
Some of my colleagues have tried PRP injection for the older patients. But I don't think the results are any different to steroid injections. I don't know if you have any experience in that.
Sure. I mean, PRP is, I do quite a bit of a PRP, and I think when you do it for the right reason, I guess if you're talking about a slightly older patient, it depends what you're talking about. Oh, some people think that 50 is old, some people think that 90 is old. So I think that's where I think PRP have a role in the age group between 50 to 60. But I don't think that any patients older than that, because if we want to do PRP, we are aiming for regeneration. We're aiming for looking at the growth factors. And I think after a certain age, our body might not regenerate as well anyways. But I think by treating that without treating the cause with physiotherapy, it's not going to work. So it's a combination, whatever injection we do. So yes, well, anyway, thank you very much for the very insightful, talk on the hips today. And we have great questions, and we have great lecture from you. Thank you very much. And I would like to thank you for the attendees that raising all these questions. And I would like to also remind you guys about the next webinar that is coming next Tuesday. So this is talking about cranial nerves. How can what do we do? If my patient have a cranial nerve palsy, certainly you do not need an orthopedic surgeon for that. So yeah, please come and join us. And we can watch our recording and the college website. And it's a pleasure to be with you guys all.
Thank you.
Thank you.